Great to see all of you. I have no disclosures. So here's an overview of the talk. So we will discuss some aspects of the classification scheme that are in place for hematologic malignancies as they relate to myeloma. We'll discuss MGUS, and then we're really going to spend most of our time discussing multiple myeloma, the pathogenetic features, diagnostic workup, and we'll discuss some of the variants, and then we'll finish up discussing immunoglobulin deposition diseases. Most of our time there will be spent on AL amyloidosis. Okay, so if we turn to the classification, I think one of the biggest things, if you will, is that multiple myeloma is now terminology that's back in vogue. I actually think that's a very good thing. In years of interacting with myeloma docs, I have never once heard one of them refer to this disease as plasma cell myeloma. It's multiple myeloma. That's just the terminology they use. So I think it's good that we're all speaking the same language. So I think that's a good thing. This is sort of an overview of the two different classification schemes. Overall, they're actually quite similar. There are some differences with regard to MGUSs, but really once we get into myeloma proper, the two classification schemes are actually quite similar. So let's go ahead and turn to MGUS then. So the definition of MGUS is that this is in fact a neoplastic pre-malignant bone marrow expansion of clonal plasma cells that by definition is in fact associated with a serum paraprotein. The diagnostic criteria are indicated here, and essentially you need low levels of a paraprotein of IgG, IgA, or IgD type. There should be a low burden of clonal plasma cells in the bone marrow. And importantly, there should be no evidence of any CRAB. And of course, CRAB's a nice mnemonic to remember the characteristic hypercalcemia, renal insufficiency anemia, and osteolytic lesions that can occur in the setting of myeloma. So in IgM, non-IgM MGUS, these should be absent. There is a variant of non-IgM MGUS, and this is the light chain type. And in this particular variant, as its name implies, there's no evidence of an associated heavy chain, at least as assessed by immunofixation electrophoresis. In these patients, there should be significant elevation of the involved free light chain ratio, and so the kappa lambda free light chain ratio, depending upon which is involved, is either markedly